All right. Well, here we are on Healthcare Unfiltered. And this is really an important episode. We are taping it sometime in mid-July. It's not going to air for a while, actually. I was looking at by the time you listen to this, will be several weeks from now. But I'm really very interested in this because I came from a country called Syria, and it's extremely we did not have all of the medical technologies and all of the medical resources that the US had. And before we went on the air, I was telling my esteemed guest that, there are times where I actually did have to utilize the stethoscope to even know what's going on. And then when I came here, I realized I rarely needed this because I can just do CAT scans and echoes and everything on everybody. Look, having said that, our goal here is to discuss oncology care in low middle income countries. So with that, I have two amazing guests, and we'll start by introductions. Nikita, why don't you get us started?
Hi, Shadi. Thank you. Thank you for the warm welcome to your show. So I'm Nikita Mehra. I am a practicing medical oncologist. I completed my training in medical oncology in 2017. And I've been serving as a faculty member at the Adyar Cancer Institute, which is a regional cancer center in South India. It is in a place called Chennai. And I am pursuing my career as a clinician scientist. So my clinical work involves the management of adult hematological cancers with a focus on plasma cell disorders, especially multiple myeloma. And I also manage adult soft and bone and soft tissue sarcomas. Additionally, I am pursuing a PhD in molecular oncology. So I essentially spend 50% of my academic time in the lab, where I am working on a project which is essentially on epigenetics in multiple myeloma and its precursor states.
Great, thank you very much, Nikita. Nikita, just to understand, so currently in your faculty position, do you see all cancers, or you just specifically see only sarcoma and plasma cell dyscrasias?
So there is an overlap at times, but I'm mostly focused on adult hematology and sarcomas. We've been able to expand our team over the years, and we've slowly moved towards multidisciplinary care. So we try and focus on our areas of interest. But of course, if there is a colleague who's not going to be around and wants me to cover for them, I'm more than I would help in the area, but yes, mostly focused on all of my focuses on these areas.
Great. And from South America in Brazil, Guilherme?
Hi, everyone. Thank you, Shadi, for having me in your podcast. My name is Guilherme Perini. I'm a hematologist in São Paulo, Brazil, where I work both in private hospital, but also in the public hospital. I have a public lymphoma clinic. My main focus is on lymphomas, and I try to navigate all the scenarios that I have here in São Paulo. I like to say that in Brazil, we have different Brazils inside of Brazil. So there's a lot of differences in how we approach patients, and I would love to discuss that with you.
That's great. And it's very difficult to have somebody from Brazil and not talk soccer. So I'm going to try. Who do you think is going to win the World Cup, Guilherme?
Well, I think France is still strong. I don't think Brazil stands a chance. We have to. We're always, trying to get there, but I don't think we're going to have a lot of success this year. Not really, positive about that.
I think Dr.
What about you?
Dr. Alan Skarbnik probably is having a heart attack right now if he's listening to this. I think France is very, very strong. I don't like their style. I feel they're very aggressive. They remind me of Italy in the 80s, where they were very focused on defense. I think they're very physical. I don't think Brazil is very strong, but I've learned that sometimes in the World Cup you don't have to be the very strong one. Sometimes luck is usually what will get you. All right. So we're going to talk about oncology care in low middle income countries. Nikita, when we say low middle income countries, do you have what do we know what we mean by that? How do we define these countries?
So essentially, this is a list that's put out by World Bank, and it goes by GDP estimates. And India does come under low and middle income countries. Of course, I do understand that there can be. I'm sorry. Should I even speak about this? Were you going to ask a question?
You could speak about everything. It's healthcare unfiltered. That's what we love. That. Go ahead.
So can I talk about differences in access within the country itself?
Yeah.
Or you ask,
we're talking about low middle income countries. So I want to try to understand, how do we define them? I mean, I don't, that's what we need to define. What are low middle income countries? So we have a set and stage, because obviously every country is different. There are variations within each country, but as a country, is India defined as a low middle income country based on the GDP, like you said?
So yes, India is a low middle income country. Now, of course, there are differences in access across the country. You do have some states where the access, there is a lot of heterogeneity, a lot of variation within the country. And essentially for cancer, we're actually divided into 6 zones. Now, Chennai, as I mentioned, falls under the South zone. So there are some zones where access to cancer diagnostics and treatment are possibly a lot more. Now, having said that, India is a country where private, more patients are get health. I'm sorry.
Yeah. I mean, I think what I'm learning from what you're saying, Nikita, is that the actual GDP for the country as a whole positions it in a low middle income country. And then within that country, there are obviously variations. Some people may not even qualify for this, which we see that in every country. I mean, where I came from, if you can pay for your whatever, you're going to get what you can actually get. Guilherme, is that the same? Like Brazil is based on the GDP falls under this?
Exactly. The same thing happens in Brazil. So actually it happens in the same city. So I live in São Paulo. It's a big city. And in my private practice, I work in a very upscale hospital that we have everything. We have PET CTs, we have molecular biologies. We're starting our CAR-T program in our hospital, our in-house CAR-T program. But if I maybe get my car and drive 30 minutes away from here, where I have my public lymphoma clinic, the things are different. Access to drugs are different, access to transplant is different. And if I drive maybe 2 hours from here, things will be completely different. In Brazil, we have a very developed south and southeast. But if you go up to north, where you have the Amazonia and the health system for cancer is it's starting to get more organized. So we have this difference inside. I actually come from a place a little bit in the center of Brazil, more to the north, and it's completely different from São Paulo. So it's a lot of different scenarios inside the same country. And I've been working with our colleagues from South America, and this category of low and middle income, there's a lot of difference between practice. So we have people from Cuba, people from Guatemala, and access is completely different in these countries.
Frankly, even here in the US, let's not fool each other, right? I mean, in the US, we know that there are variation in cancer care. And certainly you could imagine that there are certain parts of the United States that if they were a country, they would actually be low middle income countries. So I think there is no question that access to care varies in each country. But at least to Nikita's point, based on the World Bank, they're saying, well, these are the low middle income countries based on the GDP, probably based on the wealth, maybe based on the average income of a patient or of a person. I should have researched that a little bit before, but I think that is fair, and that obviously affects the way we do medical care. Guilherme, you mentioned is very interesting. In your private hospital, everything is available 30 minutes away. It's not available. And probably the same with Nikita, what she's alluding to, certain areas, you get what you want, other areas don't. But we're going to talk probably in general. So Nikita, let's start by screening for cancer before we get into diagnosis and then treatment. When it comes to screening right now, and I know you're doing adult hematology, so you may not always have a good grasp, let's say, on screening for colorectal or screening for breast or lung cancer. But is the sense that India is doing screening programs for patients with cancer? Are screening programs available to all patients, all people? We don't know if they're patients. Screening is in healthy people. Tell us about screening in India.
So again, as I mentioned about India, we're obviously urban and rural, and the rural occupancy of India is actually a lot higher. The representation is almost 80% and 20% is urban. So of course, you have more access in urban India. Now, as far as cancer screening programs go, we do have a significant number of programs that are going on that are government sponsored. There's a lot of non-governmental organization sponsorship into cancer screening programs. Our institute, Adyar Cancer Institute, actually runs a very large cancer registry. So it's called Tamil Nadu Cancer Registry Project, and it covers a certain number of areas in rural Tamil Nadu also. But you do have access to cancer screening, free cancer screening programs. Again, it really depends on the access is definitely going to be a lot lesser in areas that are more inaccessible. Now, the other thing that I must point out about India is that cancer registries, we come under the National Cancer Registry Program, and they've been doing brilliant work. Having said that, not all the states across the country have made cancers notifiable. So, for example, the state that I come from, Tamil Nadu, was the first state that made cancer a notifiable disease. So by law, if a patient is diagnosed with cancer, it has to be notified to the registry. So the numbers may appear larger in some states when compared to the rest, but that's really because in some states it's not notifiable.
Interesting. That is actually very interesting. And probably some states, they don't enforce the screening program, maybe. But so a woman in India, 50-year-old woman in India, she can get a mammogram free.
Yes.
Yes. Okay. And colonoscopy and so on, these are available in terms of screening. There are government-sponsored programs and there are private programs, but it's available. And the guidelines that you have for screening are different than what we have guidelines in the US, or the same?
So I have spent about 2 or 3 months in the US, and I do have a minimal understanding of how things go on there. Over here, it is not, you don't get calls from your insurance companies, whether it's private. Now, we also have a significant, excellent coverage in terms of government insurance schemes across the country. And they are trying to include or increase the reach to as many people in the country. But having said that, the cost that goes into these are packages that are there for cancer treatment. I don't think we have a separate cost for cancer diagnostics. And even if, like I said about a private insurance, if I do have a private insurance policy, I'm not going to get phone calls from the insurance company reminding me that this, you have your yearly or 5-yearly annual check or your 5-yearly check. That does not happen. So it is something that that really
it's not very cohesive, but I like the idea that you have these registries. Really very interesting, because
it's
you
more
capture.
patient, it's
Yeah.
more a person. I mean, if I'm
Yeah.
sorry, you need to edit this part out, but what
I hear what you're saying. I think you're talking about it's
it's
patient
voluntary.
driven. It's patient driven. I mean, the patient has to
Yes.
drive this. You're not gonna. Frankly, it's the same here. Sometimes insurance companies call, sometimes they don't. But I see what you're saying. It's a patient driven screening program where if the patient doesn't do it, nobody's going to call them and say do it. But the physicians could enforce that as well, right?
They can, of course, they can. They do it.
Yeah.
But again, I mean, the population, 1.4 billion. Now, in terms of course, a mammogram is available for free. One can access it in government centers, but is it available across the country? And the simple answer is no. Are there trained radiologists in every single center, especially in rural centers? In rural centers, you may not even have access to a mammogram. So essentially, it is free, but they're going to have to travel very long distances, and how many are going to really be able to do it? Which is why you have all these programs where everyone is reaching out, or even from our center, when we have screening programs, we're not essentially telling them to come to a particular place for screening. We reach out to them. And in that way, you're probably able to access, or people have more access to these screening facilities.
That's great insight. Guilherme, what's the, to the extent that what's the extent of screening programs in Brazil, and are they like available? I mean, I think it's really more, I always believe that wherever country you're in, if you have the money, you're going to pay for it and you'll get it. I think we know that even in the US. But my question is for the general population, is it screening? Are they guidelines? What's your sense of what's going on there?
Well, let's start with the one thing. In Brazil, about 20% of people have a private insurance, so they can, have access to a clinician and screening and everything. The other 80% people relies on our public system, and our public system is a very good one. But again, the problem is the number of people that we have. So sometimes you can have access to a mammogram, but it will take you 2 years to be called to do a mammogram. And that, of course, impacts.
Hold on, 2 years?
Yeah, probably for some people. We have colonoscopy, I would say even more. So we don't have, a really strong colonoscopy program for colon cancer. That actually impacts how we see our patients. For example, cervical cancer is the third most common cancer in women in Brazil, and it shouldn't be. I mean, you can, if you have screening for that, you can avoid this high number of patients. And it's even in as I said, in São Paulo, we see difference. For example, we have this public clinic and the private clinic, and I talked with my colleagues from oncology. The number of cancers that present with advanced disease in the public clinics are way higher than in the private ones, because we don't have fast diagnosis, we don't have the screening. So we have that, but due to the high number of patients and high number of population, it usually takes more than it should. So you have maybe a colonoscopy every 5 or 6, 7 years, because you don't have all the screening possibilities here.
And that's actually an important point you allude to, and maybe it's the same in India. I mean, screening obviously is not a medical emergency. It's in healthy people who have no symptoms. So I could imagine even in India, and correct me, Nikita, if I'm wrong. I mean, even in India, you mentioned the distance that people have to travel to get to certain centers, but I presume that there's probably also a wait time. If the doctor recommends a mammogram, I don't know, does it happen? Can it happen next week, or they may have to wait several months to get that done?
I think if they're willing to travel to the particular center, it's not going to take very long. We do have some hospitals like Tata. Tata is now developing centers in many parts of the country. So I think it's all about them being able to actually come to the center. The access to screening programs in their home, even these screening programs from our institute, for example, our reach is not that wide. It is a good number, it's a significant number. But again, if they cannot travel to these centers, it's going to take a very, very long time. If they can, it's not going to take very long.
But you mentioned the 1.4 billion population. I could imagine there are not enough centers for everybody. So I could imagine this. Okay, let's move from screening to diagnosis. Obviously, the diagnosis of cancer is more than just doing CAT scans, and even more than just doing a biopsy, because there are certain nuances right now today in terms of molecular profiling, and Nikita is doing a PhD in molecular biology. So Guilherme, let's start with you. When it comes to diagnosing cancer, these fancy methodologies that we do here, how available are they? And frankly, you are specializing in lymphoma, where there's like 60 types of them, where you need some of this. But this is not about lymphoma, just in general.
Yeah, well, it's usually not available for maybe 80-90% of patients. If the patient is lucky to go to a really specialized center, you probably have access to FISH or karyotyping. But for most of patients treated, we don't have a lot. In hematology, we don't have FISH for probably not any disease. Most of the molecular testings are not available. We rely mostly on biopsy and immunohistochemistry. So I don't have, for example, for myeloma, we're actually just starting to get some people to get FISH in the public system. For lymphomas, we don't have any of that. CLL, we don't have these tests unless you are in a specialized center. So it mainly relies on biopsies and immunohistochemistry for most of the patients.
So when you have a CLL patient, let's take that as an example, you're unable to tell if the patient has 17p deletion or not?
Yes. So in Brazil, some of the pharma gives you like a voucher so you can have this information. But unless you do like through these programs, you don't have that. You can just treat them blindly regarding molecular testing.
How about when you do staging? Are you able to do PET scans on everybody? Is that available? Or you have to wait? I mean, sometimes you may have it available and they will say, well, you gotta wait 2 months, and you can't wait if you have Burkitt's or large cell lymphoma.
That's what usually happens. So PET in our public system it's approved for lymphomas, right? But for most of the time, a PET CT can take up to 2 or 3 months. So not in my public system, I'm lucky because I have a partnership with my private hospital, so I can have access to PET in 1 or 2 weeks. But for most patients, they probably won't have the initial staging PET because it would take so much. Interim PET, usually you have to ask for this PET at the time of diagnosis, so it takes 2 or 3 months, and you can have an interim PET. And end of treatment PET, you probably do it 2 or 3 months after patient has finished the treatment, because the delay in getting these tests done.
And that is, you're talking the public system, but you're not
public system,
the
yes.
private system.
In the private, you can do it in 1 week or 2.
So the private system is what? This is like analogous to the US as private insurance? like Blue Cross
Yes.
Blue Shield and Cigna and United, and then the other one is like the county system?
Yeah, so the private, we have different, private insurances. You pay out of pocket, and then you have access. So most of our population cannot afford private insurance. So we have this national health system, and it kind of it has an hierarchy that you have. Some things are from the cities, some are from the states, some are from the country. It's kind of messy sometimes to see which one is responsible for that. But the thing is, most of patients won't be able to get all these tests at time, or not even never, because they are not available.
So just to go back, so when you look at the population in Brazil, what's the percent that have private insurance versus the percent that they don't?
Well, before the pandemic and all the crisis that follows, it would be about 18 to 20%. I believe now will be around 12, 15% of patients with private insurance.
So almost 85% of the patients, of the people in Brazil, have to rely on the public system that you mentioned.
Exactly.
So that's really the majority, the
Yes.
vast majority. So all of this applies to them.
Yes, unfortunately, yes.
How about, so that's for PET. CAT scans and MRIs are easier done?
CAT scans are easier. MRIs will take a long time, because it's a unified, waiting list. So if you have an MRI for headaches, it's the same waiting list for an MRI for bone disease. And even, for example, myeloma, we only do bone assessment by X-rays. We don't have, PETs or MRIs, and so it's.
So when you have to take care of patients, you really have to, I mean, that's really all you have. It's not like there's nothing you could do. You still have to do your best and treat patients with the little information you get.
Exactly.
Nikita, in India, when it comes to diagnosis and staging, I mean, goodness, you're in myeloma field, which is becoming very complicated in terms of how much information to get. How available are these? And again, I don't want to talk about the ultra rich people who can get anything. I mean, we all know this, it happens everywhere. I'm just talking for the average patient. Take us through the journey and how easy it is to get these tests. And do you have these tests on everybody, or you just have to operate based on incomplete information?
So one is with multiple myeloma, the presentation is heterogeneous. Patients have gone to several specialists before ending up at your cancer center. So they've obviously spent a lot of money. They've exhausted a lot of the funds they have. Now, when I mentioned about these government-sponsored insurance schemes, we have a robust state health insurance scheme, which has collaborated with the center. But, like I previously mentioned, there's no cost for cancer diagnostics. So everything is paid out of pocket. So the patient is paying for a fish, for multiple myeloma over and above bone marrow studies, and say you get a PET scan or even a skeletal survey, which is X-ray assessment of all the bones, and a serum protein electrophoresis. These might not be very expensive, but beyond this, a serum-free light chain, an immunofixation electrophoresis, a PET scan, a fish, these are very expensive for the patient. Even if you subsidize the cost, the issue I find with an investigation like immunofixation electrophoresis or the serum-free light chain is there is a cost that is associated with purchasing the kit itself. So it's very, very difficult to subsidize or to bring down the cost to lower than the kit, because every hospital is then going to run at massive losses. So honestly, it's very difficult, because the patient says, I've spent 2,000 rupees to travel to come and see you. You're telling me to now pay 3,000-4,000 rupees just for the immunofixation electrophoresis. And it feels a bit unfair. So, it's really okay if we're not doing all these tests. We establish the diagnosis, the staging. We're okay with just the ISS where you don't have information on cytogenetics. And that's really one of the reasons why I've even chosen to do some research in the area. If you get funding, then you can actually do some of these investigations for the project. Like your funds are allocated for cytogenetic assessment. So the patient thankfully gets it done for free. So essentially, it might sound very naive, but one of the reasons to really pursue research or a PhD is to really look for other ways in which you can help patients access more number of investigations without pushing them into absolute extreme difficulty. And again, at follow-ups, you don't have an amount that is allocated from the government health schemes towards these diagnostics. So again, they're all out of pocket. So really, if the patient has a light chain myeloma and the patient is doing well, clinically, the patient's doing fine, you can't really push them to do a serum-free light chain or an immunofixation electrophoresis. You just have to go by other parameters.
It's amazing. It's amazing. I think for everybody who is listening, really, to me, I'm fascinated by how much is being done in other countries and how you're able to help patients with the little information sometimes you have. I mean, it reminds me. Yeah.
Can I tell you one thing that's going to put perspective? I'm really interested in, and I was really happy to talk to you about that, because my understanding in social media is that most of people don't know what happens in other countries. So it's really good that you're doing this. And I do a voluntary work in Mozambique, in Africa, with the people from MD Anderson. I was trained at MD Anderson, and when MD Anderson was starting this program, they went back for people who speak Portuguese, because in Mozambique, Portuguese is the language. And when I arrived there, we're always complaining of what we don't have. But when I arrived there, I see totally different scenarios. So they don't have flow cytometry. They don't have immunohistochemistry for everybody. So I think when we talk about, oncology, I think there's a lot of countries that are being neglected. We're lucky to be in India and in Brazil, that would be, in the up part of the low and middle income countries, but there are really countries that are struggling a lot with cancer, and we're not talking about them. So can you imagine a country where the first Gleevec was given to a patient maybe 4 years ago? So that's what we found in Mozambique when we arrived at. We had to go through Max Foundation. I don't know if you heard about Max Foundation. They are a foundation that gives treatment for patients with CML. So we have to go through them to get donations so people could get Gleevec in Mozambique. That happened maybe 2018 or 2017. 100% of leukemias don't have karyotyping. So there's a lot of things going on in the world that we need to address and to talk more, so we can bring these things to light, and help these people. So MD Anderson is now doing a fantastic work on screening cervical cancer in Mozambique. Cervical cancer was the most common cancer in Mozambique. Now they're training people and doing programs to go there and trying to make diagnosis in early stage disease. Mozambique there is no PET-CT in Mozambique. The radiotherapy started maybe 5 years ago. They didn't have radiotherapy in the whole country. So we need to bring these things to light, so we can develop programs and help other countries. So global oncology, care can be more, level. So everybody get at least, the minimum.
This is amazing. And if you have not written about your experience in Mozambique, I would encourage you to do that. I think I was not aware of anything that you mentioned. I do think puts things in perspective. And frankly, for you, even being at MD Anderson at some point, you're pretty spoiled, let's face it, right? I mean, everything is at the tip of your fingers. So even going to Brazil from MD Anderson is a huge change, because even from MD Anderson perspective within the US is also way different access to things. I want to move to treatment. Again, obviously there are differences between Brazil and India, and also maybe you're already alluding to this, Guilherme, about Mozambique, so maybe you can give us some perspective on that in terms of therapy. So how available is our current treatments, Nikita, for you in India? I mean, I don't know, use myeloma as an example. It doesn't matter to me, but if you're comfortable with myeloma, use myeloma. I mean, can you get everything? Can you get daratumumab? Can you get pomalidomide? Can you get, tell us, what can you get? And again, please exclude the folks who can pay millions of dollars and get what they want, because that happens everywhere. I'm talking to the general patient who has cancer. How accessible and available the current therapies that we have in the United States of America to patients in India?
So if I have to use myeloma as an example, the first line, which is bortezomib, lenalidomide, and dexamethasone, or a Cybody, or bortezomib, thalidomide, dexamethasone, is fairly well accessible in India, thanks to the availability of generics. So we have excellent generics and availability of these drugs. Now, if a patient receives treatment under some of these government-sponsored schemes, they essentially receive these drugs for free. Again, an autologous stem cell transplant in multiple myeloma, it really depends on how many centers are offering it under these and offering transplants under these the government sponsored insurance schemes. Again, if I can talk about my state, if any patient is under the Tamil Nadu, we call it the CMCHIs, they can get a transplant for free, an autologous stem cell transplant. But can I say this for the rest of the country? No. There are pockets of higher availability of things like transplant, even drugs, right? You need oncologists, you need transplant specialists. But in terms of because of the generics, you have these drugs available. One very interesting point is pomalidomide. Pomalidomide generics are widely available in the country, and we actually get pomalidomide under our state insurance scheme for free for patients. They can come every month, take their drugs, and go back. They have to come once a month for their prescription refill. What about the newer drugs? Carfilzomib is generics are again available in carfilzomib, but the cost is not. A lot of the patients cannot afford the cost of these generics also. And again, the amount goes beyond the state health insurance scheme amount that they allocate on a monthly basis. So carfilzomib may not be possible in some of these schemes. Daratumumab becomes very, very expensive. So you have less than, if you're talking about patients who do not have adequate access or cannot afford treatment or diagnosis, then none of them can receive daratumumab. The issue really is with all the other newer drugs, right? I mean, we don't have the newer drugs. Older drugs, of course, we have everything, the oral melphalan, bendamustine, etc. But it's becoming very difficult now to access all the newer drugs unless we have generics. And again, the cost needs to substantially come down. These the government-sponsored insurance schemes should be able to really fund these drugs. A lot of the times, it's not going to be possible. So sometimes we rely on, we're very happy to be a part of clinical trials, because then the drug becomes, of course, you're looking at the methodology and you're taking it through your ethics committee, etc. but you're really hoping that your patients have access to drugs through these clinical trials. So we did have selinexor, for example. The company also opened up their clinical trials for lymphoma and myeloma in India. Of course, there is a concern about inferior control arms, etc. But when you are in a country with such limited availability, the control arms really, you're just hoping your patients can access these newer drugs. We feel the divide is increasing between high-income countries and low-middle-income countries now. My mentor used to tell me that 10 years ago, if you attended ASH, you could really practice everything that you learned over there in your country. But if you go today, there's so little you're going to be able to bring back. CAR-T, all these newer monoclonal antibodies or bispecifics, etc. It's going to take forever to be able to increase access in the country.
Thank you, Nikita. That's very, very helpful. Guilherme, take us through the same question, but more from the Brazilian and Southern America perspective.
Well, in Brazil, unfortunately, we don't have access to a lot of drugs that Nikita said. We don't have, for example, for myeloma in the public system, bortezomib was included this year for the treatment of patients. So most patients would be treated with thalidomide and dexamethasone, or cyclophosphamide, thalidomide and dexamethasone, or melphalan, or something like that. We don't have Lena, we don't have Poma, we don't have Dara, we don't have carfilzomib, we don't have anything for that in our public system for myeloma. Even rituximab in Brazil, we don't have for CLL, we don't have in the public system, of course. We don't have for mental, we only have for diffuse large B-cell and for follicular without maintenance. So what Nikita said, and thank you, Nikita, for saying that, is that we navigate through very different choices here. So a clinical trial and the possibility to offer your patient this kind of drugs, we try to enroll as many patients as we can, because they are life-saving for these patients. So brentuximab is not available. Immunotherapy, Pembro, Nivo is not approved in the public system for Hodgkin's.
Guilherme, for the 12% of patients with private, are they able to get those?
Yeah, now in the private, you can get most of these drugs, yes.
But for 85% plus, they can't. Can I ask you a question? So in the US, and I want to ask this to Nikita because I'm not familiar with this. So in the US, obviously, we have the FDA that approves the drugs. And then once the FDA approves the drugs, they become covered. What's the system for Brazil? Like, do you have a similar to the FDA, but the Brazilian FDA that approves these drugs?
For approval, we have our national agency that approves if a drug can be commercialized in Brazil, right? And then we have another one for oral medications that you have a list of drugs that insurance is obliged to reimburse. And then we have a third list for the technologies that will be included in the public system. So it's kind of complicated, but if and it's crazy what I'm going to say that, but it's something that happens in Brazil. If a drug, if a cancer drug is IV, it is automatically approved, and the insurance has to pay for that. But if it's an oral one, you have to go to another instance to get that approved. For example, lenalidomide was approved and reimbursed in Brazil in 2018 or 19, if I'm not mistaken. So until 18-19, even for the private patients, lenalidomide, you have to import, and we usually import from India because of the generics, and it was not really available for everybody.
Nikita, you have a Indian FDA, like you have a regulatory thing. Take us through that.
Yes, we do have an Indian regulatory body. It is the DCGI CDESCO. So they lay down the clinical trial guidelines for the country, and the other is drug access or approval of drugs. But if I can talk about a couple of things, one thing is rituximab is also available on some of these, because thanks to the widespread availability of generics, you can actually get them through government-sponsored programs. In terms of, I must mention about ibrutinib. The generic was actually available for some time, and then Johnson and Johnson, I think, won a case, and then they were able to kind of withdraw the approval of generics for ibrutinib. So they fell out of the market. So one thing in India, thanks to generics, and when we speak about LMICs, drug availability and generics, I mean, there is this documentary called Fire in the Blood, which is beautiful. It's talked about how in Africa they had no access to treatment for HIV drugs. Fluconazole was very, very expensive, and essentially it was Cipla, the Indian company, that was willing to give the drug at less than $1. So that kind of improved access, etc. So one is very, very grateful to the availability of generics, but with all the newer drugs, I don't want to go into the complexities, but there are various ways in which these pharmaceutical companies are now, the patent period is kind of extended, and it does not expire soon. I think it's called evergreening of patents, if I'm not mistaken. So that's leading to a significant delay in a lot of these drugs now coming out.
It's really interesting. And then Guilherme, when you compare Brazil to Mozambique, Brazil looks it's different. I mean, like, how do you, I mean?
Yeah, I mean, it's completely different. In Mozambique, sometimes, we have shortage of drugs, and rituximab is a little bit more complicated to get, for all patients. So it's way more complicated. I would say that, in Brazil, we are kind of, as I said, in the top positions of, the low and middle income countries. But still, most of the drugs we talk nowadays, they're completely out of our, out of our reach. We don't have any new drugs for CLL. Most of our patients in Brazil are treated with chlorambucil or FC. There's still people being treated with FC in Brazil, in São Paulo. So it really is. It's a lot of different when we see all these new drugs, and it's just not available for us. And in Mozambique, sometimes things get even harder for them. So they have to become very good clinicians, and try to navigate with all these, difficulties. But again, of course, this impacts the patients.
How available are clinical trials? I think you both commented on the fact that clinical trials are opportunities for your patients with cancer to get access to some of these novel therapies. Nikita, how available are these? I mean, do you have a portfolio of studies for all these tumor types? And then the same question to Guilherme.
There is a very nice way in which you can track this. We have the Clinical Trial Registries of India, the CTRI. So there's a website available to look at what clinical trials are available in the country. But the percentages are very low. Aju Matthew actually wrote an editorial on this in 2019. And the percentage access to cancer clinical trials in India is less than 10%. Again, access, a lot of them are pharmaceutical sponsored. About 50% was they were all pharmaceutical sponsored. There are very, very few investigator initiated studies. But again, access again depends on where the patient lives. Is the patient in rural or urban India? And again, in urban India, there are very few states across the country that have more access to clinical trials. So in terms of compared to the number of patients that we see in the country, the clinical trial access is very, very low. And again, you need trial sponsors, you need funding. Investigator-initiated studies you cannot do a lot of these studies without funding. And for someone who's got a private insurance, the private insurer is obviously not going to look after the patient. So it's the access is very, very, very limited compared to the number of patients that one sees in the country.
Guilherme, same question.
Yeah, in Brazil, we're actually becoming, more popular with clinical trials nowadays, because first, our regulatory agencies were really, really strict. So for a long time, for example, Brazil would not participate in phase 1 or phase 2 trials because you have to have all this concern about safety, and we only would participate, in phase 2 trials. Now things are changing a little bit. It would take, for example, about 1 year, 1.5 years to get approval for all agencies so you can start a clinical trial. So now it's moving a little bit, it's getting more express. So it will take about 6 to 7 months to get a clinical trial approved. And the trials are arriving, and I would say maybe 90% of them would be pharma-sponsored trials. It also depends on where you are in Brazil. So in São Paulo, for example, you can have 2 or 3 centers for one clinical trial, but if you go up to the north or to northeast, you have one for the whole region. So it's a little bit different. But I think Brazil has been doing a lot of good work on clinical trials, and it's good because if you enroll a lot of patients, quality of data is good. More people will try to get clinical trials here. So we're in a transition. We're getting more clinical trials, but it's a constant struggle to get them here.
I must mention a point about India. So there is a program that was initiated by the government of India, wherein they are trying to enhance access to clinical trials, essentially enhance access to clinical trials, which will look at researching new drugs. So there is a very organized way of doing this for oncology. They have initiated it. It's the BIRAC. So they're simultaneously looking at registering retrospective cancer data for the most common cancers, and enhancing systems which can kind of increase the number of or improve the quality of the number of clinical trials done. So there has been a good amount of funding that has gone into some of the important centers across the country that run some of these studies. So there is a lot of, and again, in oncology, things are getting better. We have a program called the National Cancer Grid, the Hematology Cancer Consortium. And these programs are essentially, a lot of us are working in silos. And, you'll see, even if you go and look at the registration, I don't want to name the studies, but very similar studies are going on in various centers individually. They've not come together. So there are some nice programs in the country that are trying to kind of bring everyone together, and that's one thing I think. Even Shadi, it's lovely you've brought us together, but I think if we have to fight for the cause of LMICs, we're all going to have to come together, because we are kind of working in silos. We don't know what's happening in the neighboring countries so much. That is among the low middle income countries, and it's really, really important that we all come together.
Guilherme, how capable are you to do investigator-initiated studies in Brazil?
It really depends on the center you are. It's a little bit difficult to get the approval because, as I said, we're just starting to get more visible on clinical trials. So it usually goes up to all, to all the instances, and then they choose somebody that's more, experienced with that. But we have some success in some areas. But again, I would say that if we look at all clinical trials, maybe in Brazil, 3 or 5% will be investigator initiative.
It's really the patterns of care and obviously differ based on where you are being seen, and that's probably across the entire world, right? I mean, it's not really. I think we all know that, and I don't know if we'll ever live to a time where everybody receives the same care, no matter where they are born. I call this the element of luck. I mean, we're lucky and fortunate if we get sick in a country where you have access to all of these drugs, and then otherwise you're out of luck. I guess in the last few minutes, I want to talk about your psychology. That is a surprise question. Guilherme, I'll start with you. You are very well versed into what's going on with oncology in your area and beyond. And when you see that patient in front of you and you realize that there will be another therapy that you wish you can give that patient that is more effective, you know that, and you just can't because you're tied-handed. How are you able to cope with this?
It's not easy. It's really not easy. And that's why sometimes I get vocal on Twitter for, comparisons on clinical trials. It's really something you have to work on and try to think about other possibilities of taking care of your patient. So that's why I'm really going after clinical trials and trying to send my patients to clinical trials that I'm not the PI, because it's really hard. It's the idea that you could do so much more, but you can't. And sometimes I try, for example, I go to the director of my public hospital and say, listen, I have to have access to immunotherapy for Hodgkin's patients. These are young patients. These patients that they have 25 years old, and I have to do something to control their disease until they can get to a transplant. So sometimes I get lucky. Sometimes I'm able to show them that this drug is needed, and they can, try to get some funding for that. But it most of the time it's very difficult, and I've seen people getting really, really depressed and burn out because of these daily choices, right? We have a much higher mortality for most of this disease, and I'm not going to say that, but as something, but we, the physicians in low and middle income countries, we're really aware of the data. We study a lot. We're not treating our patients the way they are treated in the US because we're not aware of the data. There are brilliant doctors here in Brazil, brilliant doctors. I've been talking with people from Latin America, brilliant doctors in Peru, Colombia, Paraguay, Argentina. But it's just that our choices are harder. We have to decide what we have in hand. So it's really hard. I'll say that sometimes it's really frustrating. We get angry, but you have to try to do the best for our patients. It's always about our patients. We have, the pain, but of course the pain is way higher for the patients.
Nikita, same question. How do you deal with this just as a human being, as an individual, with the psychology of not being able to deliver what you know works better because you have limited resources? How are you able to cope?
It's of course very difficult, and Guillermo spoke about it very nicely. During COVID especially, these discussions became very, very difficult with patients. With nationwide lockdowns, they weren't able to, they could not even come to collect their drugs, etc. And one has always discussed with patients and their caregivers, but I think the discussions have gotten a lot lengthier since the pandemic. But yes, it is very frustrating. There is a lot of anger, and it's difficult. It leads to a lot of burnout for sure. But you just have to keep pushing yourself. And I feel like in our country, we need to have stronger patient advocacy groups, because they're not completely aware of so much more that they could access and ask for. And we need a better representation. It's not easy, and the thing is, I mean, yes, I am privileged and I acknowledge it. Where is the incentivization for research? I mean, I think it's important that I stop talking about my problems, and we should be talking about the bigger picture. And sometimes I feel that is lacking. Sometimes we just center ourselves around everything, and you find it hard to kind of navigate some discussions. But
It's really, look, I think that anybody who is listening to this probably has more appreciation to really what you go through and what you are doing. And I don't know what to say. I just feel that I can understand how it feels to have somebody where you really know that you can give a superior treatment and you're just simply unable to. I can imagine how this will really make you feel as physicians. And I wanted just to bring to light that there's, the United States of America has 2 million cancer patients, about 2 million cancer patients diagnosed, new cancer patients diagnosed every year. And there's a lot of world outside of the USA that deals with this burden. And what applies to us may not always apply to everybody else, other countries. Before I let you go, and I'm very thankful, I always like to end with each guest provide just final comments or anything I may have not covered or not really discussed. So Nikita, we start with you. Any final thoughts, final comments, anything you would like to share with listeners?
Thank you for organizing this discussion and highlighting our problems. We need partners in high-income countries to help us improve access to cancer diagnosis and treatment. We're thankful to those who understand the inclusiveness. But my heart breaks for this the discussion with Gilmore on Brazil and how some of these generics are not available, and they're really they're not that expensive at all. Why aren't governments doing more? I have nothing else to say except that yeah, I'm grateful for you bringing us together, and I hope to see us working together towards the cause of low middle income countries as well, because like I said, access to everything is diminishing. Nothing is improving. It's actually getting worse across the board, across all the LMICs. So we're going to have to do a lot more to improve things.
Well, you're going above and beyond, and you're doing everything that you can. So thank you for everything you're doing. Guilherme, any final thoughts, anything you would like to share with listeners I may have not asked you about?
Well, just want to thank you and thank you, Nikita, for this amazing time we had together, bringing to light our reality. Our reality is a little bit different. Our choices are a little bit more difficult sometimes, but we're all here for the same reason. That's, to improve the life of our patients. So anything that we can do to do that, we have to do. So even if it's a clinical trial, if it's a suboptimal clinical trial, what we're doing here is trying to, to help our patients the way we can. And of course, doing a lot of other things. We're working with a lot of players, other countries, but at the end, we are, in a worse position, and sometimes our choices are a little bit more complicated. But thank you for bringing light to that, and I think we have to bring light to other countries. As I said, we have to talk about what's going on in Africa, in countries that are in war, in unstable countries, because as you said, it's not fair that your chance in life, your chance in curing a cancer depends mostly on where you were born or where you are at the right time.
Well, Doctors Nikita Mehra and Guilherme Perini, thank you so much for coming on Healthcare Unfiltered. Really appreciate your time, and look forward to bringing you again some other time where hopefully we have made progress across the world. Thank you.